Hi, I'm Dr. Sanket Mehta, surgical oncologist from SSO Cancer Center. When we talk about liver cancers or liver tumors, most people focus on the tumor itself, how large it is, whether it can be removed, and what is the type. But as liver surgeons, we are just as focused on something else. How much liver will be left behind after surgery? This is where a critical concept comes in, called Future Liver Remnant or FLR. In this video, I'm going to explain what FLR is, why it's essential for your safety, how we measure it, and what we do if the remnant is too small. By the end, you'll understand how this concept helps us plan safe and successful liver surgeries. Let's start with the basics. FLR stands for Future Liver Remnant, which simply means the portion of your liver that will remain in your body after surgery. This remnant has to be large enough and healthy enough to take over the liver's critical functions after we remove the diseased portion. Think of it this way, it's not just about how much liver we take out, it's about how much we leave behind and whether it can keep you alive and well. The liver is one of the most complex organs in the human body. It performs hundreds of essential functions, including filtering toxins, producing proteins, storing vitamins, aiding digestion, and regulating blood clotting. If too much liver is removed, or if the remaining portion is weak or damaged, the body can undergo liver failure, which is a life-threatening situation. That's why we assess FLR before every major liver surgery. It is a safety check, one that helps us protect you and plan a surgery that's not only effective but also survivable. So, how much liver needs to be left behind after surgery? This depends on the condition of your liver. In a healthy liver, meaning there's no cirrhosis, no chemotherapy damage, and no fatty liver, we generally need to leave behind at least 20 to 25% of your total liver volume. If the liver is damaged, for example due to fatty liver, chronic hepatitis, cirrhosis, or prolonged exposure to chemotherapy, then we need a larger remnant. In such cases, we may aim to preserve 30 to 40% of your liver, or even more depending on your individual liver condition. It's not just about volume, it's also about the quality. A smaller but healthy liver remnant may be safer than a larger but diseased one. Now you might be wondering, how do we know how much liver will remain? We calculate FLR using a specialized software that uses baseline CT or MR images to give the liver volumetry. These scans allow us to map the liver in 3D and measure the volume of the section that will remain after surgery. In some cases, we also do functional tests like indocyanine green clearance or liver stiffness test or fibroscan to assess how well your liver is working. This helps us go beyond just size and evaluate liver function too. Once we know both the volume and function of the remnant, we can decide whether the surgery is safe as is or whether we need to prepare the liver in advance. Sometimes we find that the FLR is too small to safely support life after surgery. In such cases, we don't abandon surgery. We simply plan it in stages. One of the most effective methods we use is called as portal vein embolization or PVE. In this procedure, we block the blood flow to the part of the liver that is bearing the tumor. This forces the other side, the future liver remnant, to grow and expand over a few weeks. This approach is safe, minimally invasive, and highly effective in increasing the liver volume before surgery. Another approach is the two-stage liver resection. In two-stage liver resection, we do the first surgery directing towards the part of the liver that has lesser quantum of disease. We clear it of the disease, and then the second surgery is performed for the more heavily involved disease where we remove that entire section of the liver, often after a portal vein embolization. In select centers, a more aggressive method called as ALPPS or associating liver partition with portal vein ligation may be used, but this is resort it for very specific situations. The goal of all these strategies is the same, to grow the liver remnant before surgery so that we can operate safely. Now let me explain why this matters so much. If we proceed with surgery without ensuring enough liver is left behind, the patient can go into post-hepatectomy liver failure or PHLF. This is a condition where the remaining liver is simply not able to perform the body's essential functions. This leads to fluid buildup, jaundice, bleeding issues, infection, and even death. That's why FLR isn't just a technical concept. It's a life-saving principle in liver surgery. We always prioritize your safety over the extent of the tumor removed. FLR also plays a role in deciding how much of the tumor we can safely remove. Sometimes we may want to remove more, but if the remaining liver would be too small, we just have to adjust the plan. This is where the art of surgical oncology comes in, balancing oncological clearance with organ preservation. And when needed, we use techniques like portal vein embolization or two-stage surgery to expand options rather than limit them. So if your surgeon recommends a multi-step approach or a delay before surgery, it's not a compromise, it's strategic planning for your safety. It's important to understand that there is no fixed number when it comes to FLR. Each patient is different. Your ideal FLR depends on the condition of your liver, your age and overall health, the location and type of your tumor, whether you have had previous chemotherapy or liver disease. All of this is taken into account by your surgical team before making any decision. This is not guesswork. It's precise, personalized planning designed for your body's needs. One of the reasons liver surgery is even possible is because liver has a unique ability. It can regenerate. In fact, it is the only organ in the adult human body that can grow back after partial removal. If the remaining liver is healthy and well perfused, it can grow back to near normal full size in just a matter of few weeks or months. This regenerative power gives us the confidence to remove large portions of the liver when it's safe to do so, and it offers hope for patients even with a high tumor burden. In rare cases where the FLR cannot be increased or the liver is too diseased to tolerate surgery, we may consider non-surgical options like ablation, embolization, or systemic therapy. This is not a failure, it's a shift in strategy to ensure patients' safety while still addressing the disease. The key is not to push surgery at all costs, but to find the right treatment for the right patient. So to summarize, Future Liver Remnant is one of the most important concepts in liver surgery. It tells us how much liver we need to leave behind to keep you safe and functioning. We calculate it before every major liver resection. And if it's not enough, we use proven strategies to increase the remnant before we operate. Every surgical decision is guided not just by what we can remove, but what we must protect. If you or someone you love is undergoing evaluation for liver surgery, don't hesitate to ask about FLR. Understanding this concept can help you feel more confident in the care plan. If this video helped you understand how we safely plan liver surgeries, please like, share, and subscribe to help spread awareness to others who might benefit from this treatment. Thank you for watching and take care.